All right, good morning. Thank you all for joining us. And on behalf of my co-chair, Caroline Chandler, I'm Ryan Harris, and we want to welcome you to this year's Exercise in CF update. If you may recall, about 5 or 6 years ago, exercise was identified as a top research priority by the CF community. Remember that? You know, and everybody was excited and enthusiastic, and okay, we got to do exercise. We got to have a plenary. Fast forward to today, about 3 months ago, exercise is still within the top 10 research priorities by the researchers and the CF care teams. So I think that says something to the value of exercise and what we as the CF community need to work for. There's some emerging data to really support the role of modulator therapies on exercise outcomes, but there's so much more work that needs to be done. So much more. We're just breaking the tip of the iceberg. So today, let's see. Today we have a pretty unique session that's going to kind of bridge the RT-PT kind of gap. And I alluded to this recent report about exercise being a top research priority. But what I didn't tell you, the context of that exercise was, can it be used as airway clearance? And I think, that's something that we've heard about before and we continue to hear about. And in fact, I think there's a session at the meeting about that. So I think it's something that we really need to define and really solidify and conclude, can it actually be used? So our session description, our objectives are here. We're going to have our speakers come up. They're going to have 15 minutes to present, followed by 5 minutes of questions. We encourage you to come to the mic, introduce yourself, ask a brilliant question. If you feel uncomfortable coming to the mic, that's okay. There is an app where you can submit questions, so we encourage that. So with that introduction, we'll bring up our first speaker.
Okay. So our first speaker for this morning is Dr. Katie Hurst. She is a pulmonary and critical care fellow at Thomas Jefferson University Hospital, and she's going to be talking about mechanical airway clearance therapy for us.
Hi, everyone. So my talk today will be mechanical airway clearance, a treatment of the past. I know, it's a scandalous title, but let's talk about it. I don't have any disclosures. So mechanical airway clearance therapies. We know that treatment has characteristically surrounded the need for airway clearance. We know it's been recommended to do both mechanical and pharmacologic regimens. And so what do we know from the guidelines? We know that airway clearance therapies are recommended for all patients with CF. We know that no airway clearance therapy has been found to be superior to any other. And we know that airway clearance should be individualized for each patient, taking into account their age, the patient preferences, and their history of adverse events. And then we also need to think about aerobic exercise. The guidelines tell us that aerobic exercise is recommended as an adjunctive therapy, but not a substitute for airway clearance therapies. And the level of evidence for all of this is fair. So we know that there's numerous benefits. We know that it decreases symptoms. We know that mechanical airway clearance also decreases inflammation and infections. It reduces the rate of lung function decline and the risk for pulmonary exacerbations of CF. And it also improves quality of life. But although we know there are proven benefits, the regular use of airway clearance does come at a significant time cost. often taking more than an hour daily. So highly effective modulator therapy, restoring chloride conductance, it's dramatically altered symptoms and objective outcomes in patients with CF. It's decreased exacerbation frequencies, increased and improved lung function, and it's improved nutritional outcomes. And because of this, significant attention has really shifted to determine if we can decrease treatment burden that we're recommending to our patients. And we know that there's several studies going on, including Simplify, Hero 2, that have investigated this possibility of decreasing the treatment burden for our patients and is it possible to decrease what we're recommending. So let's be honest, adherence to mechanical airway clearance, it varies with each patient. And at our clinic at Jefferson, we're really fortunate because we have a great relationship with our patients. They are very upfront and honest with us. They all tell us what they're not doing. And, and they really aren't scared of repercussions. And we appreciate that honest relationship because I think that's important. That's how we can kind of guide our patients and make decisions together. But many of them, despite our recommendations, have discontinued regular use of various airway clearance therapies. So we decided, let's focus on mechanical airway clearance because that seems to be the modality that our patients are discontinuing. And it really made us think, if we look at this, is it making a difference in outcomes? And it sparked this idea to see, is this something that we should be looking at on a larger scale? So our aim of our study was to define the prevalence of regular use of mechanical airway clearance in our patients after roughly about 4 years of highly effective modulator therapy, and to assess if there has been a trend towards worsening outcomes. And this is how we defined mechanical airway clearance, including the vest, acapella, aerobica, flutter device, autogenic drainage, manual chest PT, and a handheld percussor. And now I want to emphasize, we only focused on daily maintenance therapy. So this is at a time when our patients are stable. They're not at an exacerbation. This isn't what they're doing when their lung function is not in its stable state. So we were really just looking at their daily regular use when they're stable. And so we conducted a retrospective analysis of records from both our EMR and Port CF of our adult center. And we looked at respiratory therapies documentation is what we use to define mechanical airway clearance therapy, because many times the physicians will state what sort of airway clearance therapies patients have available, but respiratory therapy most times defined what they're doing on a daily basis. And so that's what we looked at. So we recorded both pharmacologic and mechanical airway clearance therapies. We recorded whether or not they're doing exercise for airway clearance. We monitored their lung function, and we looked at this as percent predicted of FEV1 over time. And then we also made note of all of their moderate and severe exacerbations. So what did we find? So we had 91 adult patients. The average age was 38, and 48% of them were female. And when we broke them up, we looked at whether they're using either exercise or mechanical airway clearance, and that included 70% of patients. But then we started breaking it down because some of the patients do both exercise and mechanical airway clearance, and that was 16%. The patients that were doing only mechanical airway clearance was 30% of our patients. And then surprisingly, about half of our patients here down at the bottom, so 25% are doing exercise only, and then 27% of our patients are not using mechanical airway clearance or exercising. We analyzed this. The ages of the patients who have discontinued mechanical airway clearance ranged from 20 years old to 73 years old. 71% of them were on highly effective modulator therapy. We also looked, and the most common mechanical airway clearance was still vest therapy. But when we analyzed this, we didn't find any sort of correlation between the age of the patients, their gender, their lung function over the last year, and whether this affected the decision to discontinue mechanical airway clearance. So when we take a closer look at their lung function, we see no matter which modality of mechanical airway clearance they fell into, including the ones who have discontinued it, it appears that their lung function has remained stable over this period of time, from 2017 to 2023. Now, it's also worth noting that the lines that we have up at the top here, the two groups are really exercise only and those that aren't performing mechanical airway clearance or exercise. And they do start out with a higher lung function. But I do think it's important to note that their lung function also looks like it remains stable over all of these years. Now, looking at their severe exacerbation rates over time, we see a dramatic decrease over the years. Now, before everybody starts throwing tomatoes at me and telling me that this is blasphemy, I am not saying that any of this is directly correlated with the other. This was purely just observation of what was happening. But my question was this something worth looking at on a larger scale? We know that there are many contributing factors, and we know that there's a lot of limitations with this. So what has happened over these years? We know that the FDA approval of ETI definitely could have affected this. Our patients experienced a pandemic. They were in social isolation. Many of them were able to increase their remote working, and many people were wearing masks, so there was a decrease in viral infections. We only were able to also, some of our big limitations here, that we can only assess the prevalence of what someone's current mechanical airway clearance was at the time. It was hard to say, looking back through the notes, at exactly which point did they discontinue this mechanical airway clearance. And we had a small sample size. This was only 91 patients, and this is a single center experience. And this was only in adults, so I am not making any suggestions about pediatrics. So in conclusion, we know that mechanical airway clearance is recommended in the treatment of patients with CF. And we know that almost half of our patients discontinued mechanical airway clearance against recommendations. And we did find that our patients have not experienced a significant decline in their lung function or an increased exacerbation rate during this time. And so I really think that this just suggests maybe we need to look at this more. We need to see, should this be a regular recommendation for everyone, or do we need to really individualize this? And I know that also, especially what's important with this group, is that we're looking and we see that it's stable over time, but could we be doing better? Could exercise or something else improve this?
Great, thank you. This presentation's open for questions. And while you're all racing to the mic, I'll ask a question. So you have, exercise as a potential potential therapy for airway clearance. Did you collect any information on what type of exercise they were doing to have that maintenance of lung function over time?
When we were reviewing all of our records, it was more that documentation varied so much that it was very hard to put this into group whether they're doing weightlifting, whether they're doing aerobic exercise. So no, we weren't able to specify because sometimes it was just they exercise 5 days a week.
And then just another follow-up question. Do we know why patients discontinued their mechanical airway clearance?
So I think most of our patients, it's a time burden. It's trying to balance their lives with their medical obligations of time and therapy as well. And many of them just really don't enjoy it, to be honest.
That's fair.
Yeah. Awesome.
So my question is, did they abandon it entirely or just use it as needed?
So this was abandoned entirely. So this is looking at on a daily basis. They tell us, we have stopped. I don't use my vest at all. I don't do anything.
Even if they're sick?
No. So this was only when they're at stable lung function on a daily basis. So some of these people don't use mechanical airway clearance on a daily basis when they're stable, but when exacerbating, they may use their vest and more frequent therapy. So we didn't take into account that. This is just on a daily basis at their stable lung function.
Thanks.
Yeah.
And we have a question from the chat. Sorry, question from the chat. How do you define moderate and severe exacerbation? Specific FEV1 drop, symptoms? How?
So we defined it, moderate exacerbations were the use of oral antibiotics. Our severe exacerbations were defined by hospitalizations or IV antibiotic use.
Thank you for that very elegant presentation that you've just given us. One of the things our patients tell us that they've stopped all their airway clearance is because of no sputum at all. You know, the ones with 30% lung function will say, I can't even cough up a sputum sample, so why should I be doing airway clearance? So that's, quite hard to argue against that. However, some of those patients have very bad bronchiectasis, and maybe we need to look at that whole aspect. Which are the ones that we can go along with and which are the ones we need to actually encourage to rethink it from their side by looking at their imaging with them. So that's just a comment.
Yeah,
to add there.
absolutely. And then how do you decide as well? Is it an imaging based thing? Is it based on cultures?
Thank you for your presentation. This is great. If you look at the guideline itself, and look back, the evidence is weak at best to support the routine use of airway clearance. There are no collective studies that collectively conclude that airway clearance improves lung function over time. So, I think we've been doing this for decades, and it emerged at a time where we really didn't have a lot to offer patients and haven't really fully examined or appreciated the burden that this treatment imposes on patients. So I'm very appreciative of your work and looking forward to more and more studies like yours that support this and exercise. I mean, the emerging evidence is stronger every day.
Yeah.
So thank you.
Thank you.
Thanks again. I'll add to the salutations on that. Have you noticed a difference in those who have self-discharged the mechanical clearance? And is there a difference in exacerbations or illnesses?
No. So basically what I had shown, we saw that even the people who had discontinued, if we go back here. So our patients who report doing no mechanical airway clearance or exercise is in this light blue. Oh, I don't have a pointer.
Can you click the laser pointer right over on the left-hand side there?
Oh, okay.
Select laser pointer, you should be able to.
Okay.
There you go.
Let me see. Okay, so this light blue line here, we can see these are our patients who are not doing any mechanical airway clearance. They're not exercising. And we see this dramatic drop. Now, I will also tell you, our center did go through a transition. We were at Hahnemann prior to this, and so a lot of this was trying to collect data, and this is also during the pandemic. So a lot of these visits were over telemedicine, like I had said, with all of those factors. But we do see that in their exacerbation rate of severe exacerbations, it's all decreased here. People who are exercising only, we see that it still falls here. So we didn't see any sort of increase in exacerbations in any of those. We did see a shift from severe, and I didn't include the chart here. I didn't think that I would have time. But the rate of moderate exacerbations, we do see somewhat of a shift where maybe some of these prior severe exacerbations have become more moderate, just requiring oral antibiotic use.
Okay, so so less severe exacerbation.
Yeah.
Okay, thank you.
I have one other question for you. Do you have a physical therapist in your clinic that's helping with the exercise prescription or recommendations for these patients?
We don't, but we need one.
I was going to say, there's a grant for PT, because that's one of the things that might help with deciding what to do with future studies is having somebody that can quantify the exercise that's happening more objectively so that you've got that data.
Right. And a lot of these patients who now are patients who are feeling better and have more time, I think they want to exercise, but I think it's also that many of them don't know how or what they should be doing so.
See, Matt, I just plugged PT.
You did. I'm so happy you did. And just an FYI, those grants have traditionally, I can't predict when the next one is, but they've been coming out in 3-year cycles. So the first was 2016, then 2019. There was just one in 2022. So I would anticipate another one coming out in 2025, which isn't that far away. So keep that in mind, everybody. Thank you.
Thank you.
Thanks.
Thank you, Dr. Hurst.
Next, I'm going to invite our next speaker, Akosh Berthold, to come up. He's a certified genetic counselor at Inova Health System, and he's going to be speaking about perception and participation in sport and exercise of people with cystic fibrosis in the era of highly effective modulator therapy.
Good morning, everyone. Again, my name is Akosh Berthold. I'm a genetic counselor now at Inova, but my research that I'm presenting today, I did during my graduate school studies at Emory University in Atlanta. My research is titled Perception and Participation in Sport and Exercise of People with CF in the Era of Highly Effective Modulator Therapies. I have no relationships to disclose related to the presentation. As a brief introduction to the project, CF is a genetic condition that affects almost all physiological systems in the body. And treatment of CF has come a long way, and as a result of improving care, more people with CF are living longer. Today, a multidisciplinary team of providers are typically involved in the care of CF, including physicians, respiratory therapists, physical therapists, nutritionists, genetic counselors, and more. Novel drug therapies continue to improve the life expectancy of patients with CF, and one of these therapies are CFTR modulators, which are a genetic therapy that have proven to be a true breakthrough in CF care for those who are eligible. Additionally, lifestyle-related behavior has also been increasingly recognized in CF care for improving morbidity and mortality. And one of these lifestyle-related interventions, physical activity or exercise, is now widely recommended in the treatment and management of CF, as it has, as cardiorespiratory fitness has been linked with better quality of life and longer survival in CF. We know from previous research that most people find physical activity important, but we also know that there are significant barriers to sport and exercise in people with CF. These may be physical barriers such as fatigue or exercise intolerance, And they also may be social barriers, such as fear of infections or having coughing bouts in public. People with CF generally exercise at a lower intensity compared to non-CF peers, and the adherence to exercise programs is also generally low. So we have a lot of good clinical data about modulators, but we don't really know if and how they have changed how people with CF think about exercise since the widespread adoption of the highly effective modulators. So our aim was to characterize their perception and participation of sport and exercise now in the era of highly effective modulators. For this, we conducted a mixed methods retrospective survey-based cohort study. The survey was developed by our study team that involved the entire research committee, as well as a patient collaborator and a biostatistician. We included adults with a diagnosis of CF that were recruited randomly from routine CF clinic visits between May and October of 2022. Our survey had 3 main domains that I'd like to highlight. One of them, the first one, was perceptions of sport and exercise. In this domain, we had questions such as importance of exercise or confidence in one's ability to exercise, motivation to exercise, or barriers to sport and exercise. The second section was participation in sport and exercise. For this, we actually used part of an existing survey that estimates physical activity. This was the recent physical activity questionnaire, and in the bottom right-hand corner, you can see a sort of a screenshot from this survey. And this section estimates recreational activity based on a 4-week recall in which participants, let me get the pointer out here, indicate the frequency of each specific exercise in the last 4 weeks, as well as the duration of each exercise bout. And it lists on the left-hand side altogether 35 common types of physical activities that are not only structured exercise, but also activities around the house to get a more comprehensive understanding of total physical activity. So we recruited a total of 83 adults. The table here shows the clinical characteristics of our cohort. And the way we analyzed our data was sort of to put our participants in 2 groups. Under CFTR modulator, you can see the group that was taking a CFTR modulator at the time of study. I'm going to refer to them as the modulator group. And then the group that did not take a modulator at the time of study, I'm going to refer to them as the non-modulator group. Altogether, out of the 83 total participants, 82% of them, or 68 participants, were taking a CFTR modulator during the study. Overall, our sample was representative of the general CF population, with pancreatic insufficiency around 90% in the cohort and lung function around 78% predicted in the modulator group. And there was a statistically significant difference in BMI between the 2 groups. And the vast majority of the modulator group was taking a highly effective modulator, ETI being 94% of all participants. So in the first domain, in perception of exercise, in the perception of exercise part of the survey, individuals in the modulator group enjoyed exercising more. They found it more important as part of their CF care, and they were more likely to exercise as a means to socialize. Confirming this, over a quarter of the modulator group indicated that they participate in a team or social sport yearly, whereas no participant in the non-modulator group said that they did. And then the last question in this table asked if participants felt like CF impacted their ability to exercise. And this was not a Likert scale question, but a yes, no, unsure, multiple choice type of question. And it was trending towards statistical significance, with more individuals in the CFTR modulator group saying that they did not think that CF impacted their ability to exercise. Still within the perception of sport and exercise domain, we also asked our participants to choose the top 3 barriers out of a list of 14 that regularly prevent them from participating in sport and exercise. And this question was multiple choice, that they had to choose the top 3, so these numbers will add up to more than 100%. And in general, the non-modulator group, the non-modulator group selected barriers that are directly related to CF and CF symptoms more often, more frequently. I think the most telling difference is in the last row of this table, where feeling unwell from CF was a significant barrier in only about 3% of the modulator group. And conversely, it was almost 27% in the non-modulator group. Fatigue remains a significant barrier in both subgroups. And the 2 most common barriers in the modulator group were lack of time and school and work obligation. And I think overall this illustrates that the barriers between these 2 groups might be different now to sport and exercise. So the second domain of our survey was participation in sport and exercise, and we tried to quantify exercise in an objective way using the metabolic equivalents of each of the 35 different activities that are listed in our questionnaire, as described in the compendium of physical activities. We tried to see if there's a difference in self-reported exercise participation between the 2 groups, and overall, we can't say yet. There was not a statistically significant difference between the 2 groups. On graph A here, you can see mean metabolic minutes per week in the modulator group in dark and in the non-modulator group in light. And although there was a 39% higher mean physical activity in the modulator group, again, this did not reach statistical significance. And then in graph B, you can see the mean hours per week of activity in each exercise intensity. So we wanted to look closer. We wanted to see if they may exercise at a higher intensity now compared to the non-modulator group. And there was a 55% more moderate and vigorous physical activity combined in the modulator group compared to the non-modulator group, but again, not statistically significant. We performed a power analysis that showed that we would have needed about 600 participants for this same difference to be statistically significant, keeping the ratio of our groups the same. All right, so in the third section of our survey, we asked about the effect of modulators on exercise perception and participation, and we wanted to know how their experience has changed since taking a modulator. So this section, of course, was only given to the modulator group. The figure is based on Likert scale responses with 5 scale points, and let me walk you through how to easiest to understand this. For example, in fitness level, the scale point 1 in red represented, since taking a modulator therapy, significantly worse fitness level. Then scale point 2 in orange was a little worse fitness level. Gray is neutral or no change since modulator, and then the 2 blues are little better and significantly better fitness level. And the line in the middle goes through the middle of the neutral responses. The entire bar will add up to 100%. And I think what I'd like to highlight here is that about 70% of people said that they are currently a little more or significantly more fit compared to the time before they started taking a modulator therapy. And about 70% of them also said that they are more confident, significantly or a little more confident in their ability to exercise compared to before they started taking a modulator. About a third of our participants said they are more likely to participate in team and social sports since taking a modulator. And also more than a third, 37% of them said that they are more likely now to use exercise as their only form of airway clearance therapy. We also asked the modulator group to describe the impact of starting a modulator on a list of barriers to sport and exercise. And the concept with this figure is the same. Red indicates a negative experience on the modulator. Gray indicates a neutral or no change. And then blue indicates that the modulator helped regarding that specific barrier. And I'd like to start here at the bottom. More than half of our respondents said that modulators helped with concerns about symptoms while exercising, such as coughing in public. And 55% of them said that modulators helped with their concerns over infections while exercising. And I think it's worth highlighting that a small but significant proportion, over 10% of our participants on modulators, said that worsening symptoms of depression and anxiety and weight gain or loss have now become more of a barrier to sport and exercise since taking a modulator. Overall, these findings highlight that highly effective modulators had a positive impact on the confidence level of people with CF, especially when interacting in crowded environments and in overcoming concerns related to CF. We gave the opportunity to our participants to expand on their responses at the end of each survey domain, and I'd like to highlight a few informative open text responses. The first one being a positive one that participants said that I feel like using a highly effective modulator has helped improve symptoms that would have previously prevented me from exercise and sport, not coughing as much, more energy, etc. We also received a few negative opinions, responses. The second participant saying that putting on weight as a result of a highly effective modulator has made it harder to exercise. And in the interest of time, I'm not going to read the third one. So we conclude that adults who take CFTR modulators are more likely and capable of participating in team and social sports compared to before taking a modulator and compared to those not taking modulators. This might be due to a combination of improved physical fitness, higher motivation, more exercise-related confidence, and a reduction in previous exercise barriers. There are still notable barriers to exercise, especially in those who are not taking a modulator, but these barriers now might be different in the two groups. Modulators also might help to reduce the therapeutic burden in CF, as some of our participants indicated that they now might be able to use exercise as their only form of airway clearance. And we hope that these findings can guide clinicians when discussing and prescribing exercise, especially when talking about social activities such as team sports. I'd like to acknowledge my entire research committee, particularly Eileen Barr, genetic counselor, and Dr. Hunt, pulmonologist. I'd like to acknowledge the entire adult and pediatric CF care team for their help, Dr. Murden for his statistical assistance, and all the CF patients and their incredible willingness to participate in research. And also the NSGC special interest group in cystic fibrosis for their funding.
Feel free to come forward with any questions.
Thank you for that awesome talk. We have a question from the chat. Did you consider that people in the no modulator group are often class 1 mutation, so have a more severe CF disease?
Yes, this is certainly highly likely. I think in this research, what we wanted to see is how modulators particularly have helped those who are eligible, and if there's a gap between barriers to exercise and exercise participation between the two groups. That's certainly the case, that it's likely that there are more severe variants in the non-modulator group.
Great. Another question from the chat. What was the name of the survey you used?
It was the recent, for exercise participation, that was the recent physical activity questionnaire. And we used only a subsection of that estimates, how's it described in there? I think recreational physical activity.
Great. So we know that, the use of modular therapy improves lung function pretty rapidly, but its effect on exercise could be a little bit delayed. In this group of modulator users, do you have an idea of how long they were on modulator therapy before you collected the survey data?
We tried to gather that data. It was incomplete, so we didn't look at that particularly. So I can't give you a correct and accurate answer for that, unfortunately. Most of them have been on a CFTR modulator for longer than a year at least.
We have one other question from the audience. What are some ways to ensure patients are following through with exercise and highly effective modulator therapy? How do we as providers implement strategies in clinic to emphasize the importance of doing both? Both exercise and taking their modulators.
That is a great question. I don't have an answer to that. I think it's going to take time and a collaborative effort to figure out how to do that best. Certainly data like this can help to prove that people with CF now can do it. But it's a big task for sure.
And I'll just make a comment on that. Part of your data supported that the lack of time contributes to the patient's decision not to engage in physical activity or exercise. So I think we as a community need to kind of be creative and think outside the box of what types of activities can be shorter duration, more effective than someone needing to go for a run or ride the bike, and that's the perception I think these patients have is exercise has a structure, and it doesn't have to be structured. It just has to be activity at a certain level. And I think that's something that we as a community need to do a better job educating our patients on. We have time for one more question.
Hi, Michelle Prickett, Northwestern. Thank you for a lovely talk. I enjoyed it immensely. It was well done. I really appreciate the fact that you brought barriers. I think barriers for people on highly effective therapies and not, to acknowledge that this exists as a motivation to address them and overcome them. I'm wondering if there's any additional data that you might use to, once you've addressed the barriers, as a motivational tool in terms of their metrics. So time, Fitbit, lung function, if any of that came out within your research that would help as a motivator to us. And then to build on your point, as a physician, our goal is if someone's saying time is a factor, it's, I think, our responsibility to say, what other things can we get rid of to help you exercise more? So any ideas on metrics that may have been explored that just wasn't shown today?
Any idea? Could you repeat the question? Any ideas?
I loved your
metrics?
talk so much. So my question was, are there metrics that you pulled out within your research? Was it just survey-based, or were there corollaries with lung function or time that was reported through other means that could act as a motivator for self-monitoring?
We did not look at any of those metrics specifically. So I can't give you a better response than that. I think there was no difference as far as, at least in the modulator group, as far as stratifying them by lung function. We did not find a statistically significant difference in exercise minutes, for example. So we don't have such a metric for now by which we could stratify.
Thank you very much.
Thank you.
Thank you for that very nice talk. Mine is a comment about what we tell people in clinic. And Professor Yankaskus, many years ago, in one of his articles, wrote something which I have taken away and has become my mantra with everyone I teach about exercise, and actually it probably applies to everyone in this room, which is 30 to 60 minutes per day, most days of the week, of moderate to high intensity exercise. And, I think that covers a lot of what we should all be doing, and it certainly gives patients a bit of a guideline. And then you can explain what is moderate exercise, where you can still keep walking and talking or running and talking, whereas high intensity, you're short of breath and you should be mixing it up. And I think that's kind of it's not a prescription, but it's a kind of a guideline that I find very useful. And it's become my mantra. And he was actually in the previous session, so it was very nice to tell him that what he wrote many years ago is something that we have listened to and carry out.
Thank you. Thank you for that comment. And I certainly think education is going to play a major role in how we can get our patients to exercise more efficiently and keep an exercise routine that they can adhere to better.
Thank you so much.
Thank you.
I'm going to allow our next speaker to pronounce her name for herself so that I don't ruin it in front of all of you. But she is a pediatric pulmonology fellow at the University of Arkansas for Medical Sciences and Arkansas Children's Hospital. She's going to be speaking to us today about nebulizers.
Good morning, everyone. I think we all did some exercise till now. We can sit back and relax and hear something about the nebulizer performance. My name is Kanchanamala Agoramurthy. I'm a third-year pediatric pulmonary fellow at Arkansas Children's Hospital. I work under the mentorship of Dr. Ariel Berlinski, and this research was performed at the Pediatric Aerosol Research Laboratory at Arkansas Children's Hospital. And thanks for letting me to introduce myself. Like that? Okay. I have no disclosure related to this presentation. As we all know, patients with cystic fibrosis, they use nebulizer treatment multiple times a day. These nebulizers are at risk of superinfection if they are not cleaned and disinfected properly. The Cystic Fibrosis Foundation guidelines recommend cleaning and disinfection after each use. There are two types of disinfection method recommended by the CF Foundation. The first one is thermal-based disinfection, which includes boiling, steam sterilization, and dishwasher use. The second one is a chemical-based method, which includes submersion of the nebulizer in 70% isopropyl alcohol and or 3% hydrogen peroxide. Oh, sorry. Okay. There are few literature on nebulizer performance after repeated disinfection. As you can see in this particular slide, okay. And this study showed a decrease in the solution output after 20 cycles of disinfection. As you can see here, this small little diamond represents the steam sterilization disinfection, and this one is a square which represents the boiling method. So what they did was they found that after 20 cycles of disinfection, the solution output started decreasing. However, the limitation of this particular study is, number one, a breathing simulation was not used, running a risk of underestimating the output. I'll show a schematic representation of a breathing simulator in the next couple of slides. The second limitation is a solution output was used as a surrogate for drug output, running the risk of overestimating the output. So how do we calculate solution output? Is the amount of the drug remaining in the nebulizer after the nebulization. Finally, a particle size characteristics was not analyzed. And what is particle size characterization? The next slide, I'm going to talk about that. So this is one particular study which was done in our own aerosol laboratory, which evaluated the performance of the nebulizer after 180 cycles of sterilization using a baby bottle sterilizer. As you can see, we calculated the solution output and the albuterol mass released. In the red is the albuterol mass released, and the blue is representing the solution output. As you can see, after 180 cycles of nebulization, repeated cycle of disinfection and nebulization, the drug output remained stable. So this is particle size characterization, where we evaluated the mass median aerodynamic diameter. The second one is geometric standard deviation. The third one is fine particle fraction. So these three are the particle size characteristics, which means the MMAD represents the measure of central tendency. GSD is the geometric standard deviation, which is the standard deviation. And the fine particle fraction is the amount of drug which gets deposited in the lower airways. And as you can see, throughout 180 cycles of repeated disinfection, the particle size characteristics remain stable. So the aim of this study was to evaluate the performance of a reusable breath-enhanced nebulizer after repeated cycles of cleaning or disinfection using different methods. So the methods that we used are boiling and 70% isopropyl alcohol. So we hypothesized a repeated disinfection of the nebulizer using boiling and or 70% isopropyl alcohol will not alter the nebulizer performance or the aerosol characteristics. We hypothesize the nebulizer performance will be underestimated when the breathing simulation was not used. And finally, we also hypothesize the drug output will be overestimated by using a solution output as a surrogate. So here is the method. What we did was we used 4 reusable Pari-LC plus nebulizers per group, which was operated at 6 liters per minute. And these are all the following methods of disinfection. Cleaning with tap water was taken as a control. Submersion in boiling water for 5 minutes followed by air dry was taken as a boiling method of disinfection. Submersion in 70% isopropyl alcohol for 5 minutes followed by rinsing and air dry was taken as alcohol method of disinfection. The albuterol mass was assayed using spectrophotometry. Moving forward, in the next few slides, you can see A, B, C. A represents alcohol, B is for boiling, C is for control. As I already mentioned, this is a schematic representation of a breathing simulator. So this can generate a set tidal volume of 500 milliliters, a respiratory rate of 15 per minute, and an IE ratio of 1:1. As you can see, we connected the Pari-LC plus nebulizer to the breathing simulator in series with the inspiratory filter and an expiratory filter. And this was connected to the flow meter and it was operated at 6 liters per minute. How did we calculate the solution output? So we weighed the nebulizer before and after nebulization. So the albuterol mass released was calculated by using the loading dose minus the albuterol mass remaining in the nebulizer cup at the end of nebulization. This is a schematic diagram of a next generation impactor. and we use the cooled next generation impactor for our experiment. And this is the experimental setup and the particle size characterization, which including the mass median aerodynamic diameter, geometric standard deviation, and the fine particle fraction was calculated. This is our testing schedule. So the cycles were performed daily for 5 days in a week for 36 weeks for a total of 180 cycles. NGI, which is the next generation impactor for all groups, and control without the breathing simulation was done at 30 cycles interval. Breathing simulation was performed more frequently for all the groups. In the next few slides, you'll be seeing some graphs and bar chart. So on the x-axis, you can see the number of cycles, which is 0 to 180. And on the y-axis, I'll be talking about the outcome. So in this particular graph, here, solution output is the outcome. As you can see, from 0 to 180 cycles, the solution output remained almost stable, as we can see in the small box inside, where the mean, the standard deviation, and the CV remained almost within the same range, telling us that the solution output remained stable throughout the 180 cycle. And this is the albuterol mass released. And again, there was no statistically significant difference in the albuterol mass released over the course of 180 cycles. And as you can see here, from the small box, the mean, the standard deviation, and the coefficient of variance all remain stable over the course of 180 cycles. Okay, this is an interesting slide where on the left side, you can see the solution output as the outcome, and on the right side of this bar chart, the albuterol mass is the outcome. As I already mentioned, the number of cycle is on the x-axis. This blue color bar is representing the solution output with breathing simulation cycle, and the yellow color is representing the solution output without breathing simulation. So as we can see consistently, if the breathing simulation was not used, the solution output consistently remained lower when compared to the breathing simulation cycle. On the right side, as I already mentioned, the albuterol mass is the outcome, and the gray color represents the mass released with breathing simulation, and the orange represents the mass release without a breathing simulation. So as we can see, when the breathing simulation was not used, the albuterol mass released was consistently lower when compared to breathing simulation cycles. This is a comparison between a solution, how the solution output and the drug output. So this is a difference on the y-axis. We are seeing the difference between the solution output and the drug amount, and the blue represents alcohol, the yellow represents the boiling, and the gray represents the control. As we can see in this small box, for all the groups, the mean standard deviation and the CV remains, when compared, it remains 9% more than, which means the solution output is 9% more when compared to the drug output. This is telling us when we calculate only the solution output, there is a 9% increase of the drug output in compared to the drug output. So the next 3 slides, I'm going to show the particle size characteristics based on our study. So the MMAD for all the groups for alcohol boiling and the control remained stable without any statistically significant difference throughout the 180 cycles. Same goes with the GSD as well. It remains stable without any statistically significant difference. And the fine particle fraction as well. In conclusion, repeated disinfection of the nebulizer using boiling or 70% alcohol, isopropyl alcohol, did not alter the nebulizer performance or the aerosol characteristics. And the nebulizer performance was underestimated when breathing simulation was not used, and the drug output was overestimated by using solution output as a surrogate. Thanks for your attention. Happy to take questions.
Thank you for your presentation. Just wondering, the previous study that you referenced regarding the baby bottle sterilizer, do you know what type of one it was? Like if it was one that goes on the counter or if it's one of the ones that goes in the microwave? It went on the counter. Okay. Do you know what brand it was? Just curious.
Thanks for answering.
Thank you for that very interesting study. Can you tell us when they took them out of the solutions, did they fully dry them before you used them? Or were they taken out, shaken and used sort of wet, as it were?
Sorry, can you repeat the question?
When you did your bench studies and you took them out of the solutions, either tap water or alcohol and boiling, did you just take them out, shake them, and then start using them in your experiment, or did you dry them thoroughly?
We dried it thoroughly. So that was actually the method that I mentioned, that so after boiling, we air dry, and after the alcohol, we rinsed and air dried.
So basically, with all that data you presented, there's no difference between the isopropyl alcohol and the regular water with performance?
Yes.
So would you recommend just cleaning the nebulizer with water?
So this is, that's a great question. So we are not looking for, we are not talking in terms of whether this nebulizer is going to, if you're not cleaning it, if you're not disinfecting it and then reusing it, we know there are a lot of studies saying that proper disinfection and proper cleaning, if that is not done properly, then the microorganism is going to lodge and is going to cause infection in terms of pulmonary exacerbations. So that is recommended. So I'm not going to recommend against disinfection method. Mm-hmm. So basically we are telling that this after repeated cycles of disinfection method, the amount of drug that is released from the nebulizer is not changed over time. And we did this for 180 cycles, which is actually representing 6 months of a total. So limiting that recommendation to that particular period.
Thank you very much.
Thank you.
I'm going to have our next speaker, Maggie Grossman, come up. She's a research coordinator in the adult CF program at Northwestern University, and she's going to be speaking to us about remote exercise in patients with CF.
Morning, everyone. Thank you so much for that introduction, and thank you for the opportunity of presenting today. I'm really excited to talk to you guys about the study that my group has been working on. It is a pilot study for this wearable patch to collect sweat chloride in remote exercise for our patients with CF. And I do not have any relationships to disclose related to this presentation, but 3 of our co-investigators are inventors of the technology that we're testing, and this technology is now commercially available. So the burning question is, why do we care about exercise in CF? And I think that my previous co-speakers really, hit the nail on the head with why we should pay attention to exercise. So I'm not going to go really, far in depth as to why we should care about this, but I do want to focus on what we can learn from exercise in sweat, and specifically the salt in sweat, to provide additional support to our CF patients as they continue to use exercise for their cardiovascular health, their weight management, and their airway clearance. And CF is a disease that affects the movement of chloride through a cellular channel. And as we know, there are various mutations that can cause this disease, and these genetic mutations can cause various physical manifestations due to the changing of these salt concentrations throughout the body. And people with CF have more salt in their sweat generated at rest when compared to healthy populations. And this may mean that people with CF also have a variable amount of sweat chloride in their sweat while exercising. And excessive salt loss can lead to dehydration and cramping, and can ultimately impede participation in exercise. So sweat collection in the CF population has traditionally been used at diagnosis, and most people with CF don't know their sweat chloride values besides their diagnostic value. But the sweat data collected during clinical trials for highly effective modulator therapy has demonstrated that sweat, and particularly evolving sweat values, can be a marker for physiologic changes due to CF channel modulation. And that led us to consider sweat as an outcome measure rather than just a diagnostic method. But the traditional methods for measuring sweat in CF and in exercising populations is somewhat inefficient. In CF, the process involves a 45 to 60 minute time frame where and it must be completed at an accredited center where, as you can see in this image, where we induce sweating using electrophoresis onto each arm, and then we strap a collector to the arm, and we must send the samples to a lab for analysis. And in exercising populations, it involves the wrapping of an absorbent material on the arm and then wringing it out and sending it to a lab. So it's not very time efficient. So we seek to identify a more robust method for the collection of day-to-day ambulatory sweat data for people with CF. And we're not the first people to think of this idea of real-time sweat collection. And Dr. John Rogers at Northwestern and his team of bioengineers have been developing this for 10 years. The patches that they've developed, as you can see in this timeline, they're able to analyze them using a smartphone like scanner to assess the color change in the sweat to gather data on different metabolites in the sweat and sweat chloride. And in 2020, they actually tested a patch in the Gatorade testing facility, and these individuals at Gatorade ended up buying the patch that we'll be testing today. And then in 2021, in collaboration with Dr. Susanna McCauley at Lurie Children's in Chicago, their CF group, they tested a wearable patch for pilocarpine induction in CF. You can see Lightning McQueen on that one. It's a pretty cool patch. So now we're moving into the CF realm of this ambulatory sweat collection. And so in taking into account the development of this technology, we seek to determine if one of these patches can offer a solution for collecting ambulatory sweat chloride in people with CF. And so in this study, we're taking this GX patch and we're using it for off-label for research as our CF patch to evaluate its feasibility in collecting sweat during exercise in people with CF. And we want to be able to collect sweat for CF and also remotely monitor home exercise for CF. And eventually, we want to be able to collect this data on chloride loss during a visit in our exercise laboratory and also during home sessions. And we recruited participants in our adult CF clinic at Northwestern. And so when reviewing our clinic list each week, we focused on a population that already had a cardio exercise regimen. And the reason for this is that we aren't prescribing exercise for them to do at home. So they can do whatever they want. And this is important because we also want them to be able to undergo strenuous exercise testing in our laboratory, which can be difficult for people with advanced lung disease. So that was a priority for us. And then to ensure that our participants were well equipped for this study, we enrolled people with CF that were clinically stable at baseline. So that was confirmed by our providers on staff. And this means that we didn't enroll subjects with acute CF exacerbations, and if they did develop an exacerbation during the study, their participation was discontinued. Furthermore, since the CF patch is a sticker, we didn't approach participants who had a history of a significant allergy to adhesive. And we also did not enroll participants who use supplemental oxygen on exertion or at rest. And finally, our participants who are in a blinded investigational drug study, they're not eligible for this exercise study. And so while enrollment is ongoing, I'm presenting interim data on 11 of our completed participants. And not included in this data set are individuals who did not end up completing the study, but who did enroll. And there were 2 participants who did this. So out of our 11 participants, we enrolled 6 males and 5 females. And 64% of them were Delta F508 homozygotes and 81% were on the ETI modulator. And this is representative of this data at our site as well. And furthermore, there we go. Sorry, I was one step behind. Furthermore, all of our participants were Caucasian and not Hispanic and Latino. And I do acknowledge that this is not fully representative of our site. We are striving to enroll more people of color as the study progresses. And finally, what I want to highlight is that this is a very healthy population at our site. Our mean BMI and mean percent predicted FEV1 were higher than the national average and our program average. And then finally, in data that I'm not showing you, we also had healthy volunteers. We had 4 healthy volunteers, and they were well matched for gender, age, and BMI with our CF population. So to investigate the CF patch during exercise, we designed this observational study, the RECOUP study. And it begins with a remote consent call that happens on Zoom. And then we will have our participants complete 7 days of medication and food diaries. And these diaries are just meant to get a general idea of meal times and medication times. We also remotely monitor for adverse events throughout this 7-day period. After 7 days, our participants come on site and one of our coordinators will perform a bilateral pilocarpine-induced sweat test, and we'll have the traditional macroduct collector on one arm, and we'll have a CF patch on the other arm. And after this, we will fit them with a heart rate monitor, and they will complete a cardiopulmonary exercise test on the cycle ergometer. And we measure VO2 max while tracking blood pressure, perceived exertion using the modified Borg scale on a scale of 10, and also heart rate. And impressively, our mean VO2 max for our CF participants was 29.2 milliliters per kilogram per minute. And this was remarkably similar to our healthy volunteers. And our healthy volunteers were 33.3 milliliters per kilogram per minute. And I just think that this is an awesome reflection on our PTs who are in the audience there, and also our providers for promoting exercise in our patient population. So after the CPET, we let them rest until they stop sweating, and this is important. We can't apply our next patches until they stop sweating. And then they will perform a 30 to 50 minute monitored exercise session with the patch on either arm on their forearms. And And they'll do this at 50 to 70% of their VO2 max, which is their maximum exertion. And so after this, our coordinators will show them how to scan the patch using the smartphone, as you can see here. And then we'll send them home with patches, heart rate monitor, and phone. And they'll complete more daily diaries for 14 days that capture the same data that we did for the pre-enrollment period. And then 5 more detailed exercise diaries for their 5 home exercise sessions that they will do over 14 days. And they can do anything they want. They can't swim with the patches on. They can do anything else though. And like I said, we're not telling them what exercise to do. We really want them to do whatever they do normally. And we'll also look at all the data in real time and look at their heart rate and check in with them via text, email, surveys, and phone. So now I'm going to discuss what we've gathered from our on-site portion. So as a reminder, this is our sweat test and our on-site exercise session. So we think the patch worked pretty well on site. 91% of our participants were able to obtain a successful sweat collection. And on the left here, you can see a pilocarpine collection. You can see the redness from the induction. And this is successful because we can see orange here, which is where we get our volume value, and we can see purple here, which is our chloride value. And then on our on-site exercise session, 82% of them were able to obtain a successful collection. And that image is on the right. So with our rate of success from the sweat induced from pilocarpine, we were able to compare the CF patch collection with the macrodot collection. And this graph here, we're comparing this. So, for the next 2 graphs I show you, we've plotted each participant as a point. Our CF participants are in orange and our healthy volunteers are in blue. So here on our x-axis, we have our macroduct sweat chloride. On our y, we have our CF patch sweat chloride. And if they were exactly equal, you would see everything on this dotted line, which is 1-to-1. And they're not exactly equal. But the solid line in this graph represents our model, which shows a good linear relationship. Our R-squared value of 0.82 indicates a strong correlation between our line and our graphed points. And this means that our macroduct value can accurately predict a patch value and vice versa. Now, it's important to note that using this model, we might be seeing that for a given increase in macroduct, we might be seeing a larger increase in patch sweat chloride. So I just showed you what it looks like when inducing sweat with pilocarpine, which is done for diagnosis. And now we're moving on to the exercise portion. So this is all CF patch, no macroduct collector. But on the x-axis, we have our pilocarpine induction, and on our y, we have our exercise induction. And now this is very novel data on how this patch performs. And as you can see, if everything, like I said before, if everything was equal, we would see it on our dotted line, and it's not. There is variability. What we do know is that the patch is capable of collecting sweat during pilocarpine and during exercise. And although for our small sample size, this is showing that there's a smaller jump in exercise sweat chloride for a given increase in macroduct sweat chloride. And we haven't fully looked at what can account for these differences. So now I'm going to talk about our home data. And so our home data is these 5 exercise sessions. And if they were unable to obtain a successful collection, we do have the option for 2 more exercise sessions. And our participants did find success at home. 82% of them were able to have 2 exercise sessions where they had a successful collection. So this right here on the right is unsuccessful. We can see backflow. We don't see purple. And luckily, it was great to see that we had mostly patches that looked like this. And we were really interested in what types of exercise our participants were performing at home. So this is a chart of all the 54 exercise sessions that our participants performed, and 72% of them were able to do at least 5 workouts. So we saw that 74% of these workouts were some form of endurance training. That can be high intensity interval training or moderate intensity steady state training. And then 20% contained a resistance training element. And of note for our population, our resistance training sessions also included some form of cardio as well. And then 6% was flexibility training. And for us, this was some form of yoga. And so we're interested in the type of exercise, but also the intensity of exercise. And that's because it's really easy to work hard in a lab when you see your physician right before. And it can be a little bit more motivating, I suppose, when people are looking at you the whole time. And it's harder to do that at home. So we quantify exercise intensity as an average percentage of their maximum heart rate. And we do this because it's proportional to their maximum output of their VO2 max. So this is a graph of our average percent max. And in red, we can see this is one value, their average percent max for their exercise sessions on site. And in green, it is their average percent max at their home exercise sessions. And this can be from up to 5 exercise sessions. So it's essentially an average of an average. And what we saw is that our participants exercised at 83% of their max on site for workouts that ranged from 30 to 50 minutes and 75% at home for workouts that ranged from 20 to 210 minutes. But we also saw using the Borg scale that our participants' average perceived exertion, which was self-reported, on site it was 5.2, and at home it was 6.3. So overall, we're seeing a pretty equal intensity on site as we do at home. Skipped ahead of me. Yikes. So as we progress through this study, we have been learning a lot. And what I want everyone to take home from this is that the CF patch can predict a macroduct sweat chloride. And it also can consistently measure sweat volume and sweat chloride during our pilocarpine sweat test, our on-site exercise, and our home exercise. And we also are able to remotely monitor exercise in people with CF using this heart rate data, which can tell us about their exertion. And with that said, we are limited by our technology. We did have some issues where the heart rate monitor wouldn't work, and then we lose all that data. So it is really dependent on our technology for this study. Thank you so much to my team, my mentors. I couldn't have done this without you guys. And I'm open to any questions.
Hi, thanks so much. I'm Eleanor Muse from NYU. That was a really interesting talk, and you did such a nice job sharing. My burning question is actually about your healthy volunteer with the indeterminate sweat. Can you explain what was followed up for that individual, and are they in fact okay? Because something is amiss.
My PI warned me that there would be a question on this. And so really, I don't have a very clear answer for you. I don't think that person has CF. We're in the future for this study, we're going to be looking at the effect of diet and hydration on these values. And I want to say with my limited knowledge that could have played a role. But if I'd like to call on one of my PIs if they want to contribute anything else to that. But that's we're unsure, but yeah.
Margaret, very nice presentation. In healthy individuals, we know that sweat concentrations vary quite a bit depending on where you are in exercise, at the beginning phases, middle, and latter parts of exercise. Where was the sweat actually collected when they first hit that threshold of VO2? Was it after they were at steady state for a while, or towards the end? Because as we all know, when we exercise, we definitely sweat at different rates throughout the activity.
That's a great question. Thank you very much. So we measured our sweat on site. It was immediately after they finished their exercise session. And so they get off the bike, they sit down, we scan the patch. So it's like immediately after. And then at home, we did our best to tell our participants to take the image as close as possible to when they decided they were done exercising. So this ranged in between 0 minutes to 7 minutes post when they reported their exercise session being done. Yes.
Continuous correction.
Yeah.
Just a sidebar question. I know this was about chloride and sodium. Does the technology allow for other electrolytes to be measured? In particular, magnesium is a very popular one that athletes are trying to adjust for.
So the patch that we tested, it's just chloride and volume. But in previous iterations of the patch, which let me see if I can pull it up for you. There was the ability to do this. So for this 2016 and 2019 patch, you were able to see like glucose, magnesium, that sort of thing with those.
Thank you.
Mm-hmm.
So I'm just curious about quantifying this chloride concentration, because it's a continuous collection and you take a snapshot of the varying concentrations over time. So do we know that, at different phases, there's different rates of concentration? And then how do you adjust the chloride concentration at that point of time for the data, the amount of time that you're collecting?
So we haven't gone into the more in-depth calculations yet. And that's something that we're going to begin working on in terms of sweat rate and actual chloride loss. That's when we'll bring in time. But as of right now, like you said, it is just a snapshot, literally, because we're taking an image of the patch at the end of the session. But that's something that we're definitely wanting to look into in the future.
Thank you for this talk. I find this very interesting. Do you know, have you looked at, does temperature have an effect on this? And if so, are you going to attempt to adjust or correct for that?
So we did adjust for temperature on site. We just kept track of how warm it was. We didn't keep track of it for their home exercise sessions, just to promote them to do what they would normally do. In terms of temperature, we did offer one standard layer, which is isolation gown, like an ICU isolation gown on site, and then they could wear whatever they wanted at home. But you're right, in the future, I think that's something that would be really valuable to look at, because it can also affect heart rate as well and exertion.
Thank you.
Maggie, I got one more question for you here from the audience. It says, do you have any Bland-Altman data for limits of agreement between CF patch and pilocarpine method?
Can you repeat that?
So
I'm not sure I completely understand that.
I had a question that kind of tailors into this. You presented regression data, and your R-squared value, I think, for the exercise and the pilocarpine was about 59% for agreement, but that's only one way to test for relationships between two. So the question from the audience is, there are more rigorous ways, perhaps, using Bland-Altman plots or interclass correlation coefficients or CV prime. Have you looked at any of these other relationship metrics for these outcomes?
Not yet. Not yet.
Great. He could explain that, because I couldn't.
No, me either.
Awesome.
All right. Thank you very much.
Okay, I'm going to welcome our final speaker, Ashley Berry, to come up. She's a respiratory therapist and PhD student in the Department of Physical Therapy, Rehabilitation Science, and Athletic Training at the University of Kansas Medical Center. And she's going to be speaking to us about sustained exercise in adults with CF.
Get you a little.
Thank you so much. Okay, thank you so much for that introduction. So yes, I'm going to be presenting on a study that evaluated the impact of sustained exercise on cardiorespiratory fitness and lung function in adults with cystic fibrosis. I do not have any relationships to disclose related to this presentation. So first, a little bit of background. The use of chronic inhaled therapies and chest physiotherapy has declined since the widespread use of highly effective CFTR modulators. This simplified study demonstrated that treatment can be simplified for people with near normal lung function without detriment. However, we don't really have a lot of information regarding the long-term impact of a reduction in chest physiotherapy. So cardiorespiratory fitness is a strong independent predictor of morbidity and mortality in cystic fibrosis. Exercise happens to be a great way to improve your cardiorespiratory fitness, and it also comes with a host of other additional benefits, as well as some additional airway clearance. So exercise might be an ideal alternative to conventional chest physiotherapy. So therefore, our study had two primary aims. The first was to examine the feasibility of a home-based tele-rehab intervention, and the second was to evaluate the impact of a home-based exercise program in people with cystic fibrosis for improving clinical and patient-centered outcomes. So this was a pilot and feasibility study that took place at the University of Kansas Medical Center. We enrolled 21 individuals who were approached from their outpatient cystic fibrosis clinic. Those who consented had all of their initial data collected on the same day. So they underwent a few different questionnaires that I'll review later, a xenon MRI, and an incremental shuttle walk test. Those that were randomized into the control group received usual care. So for the subsequent 12 weeks after their enrollment, they were still encouraged to participate in physical activity, but they did not receive any of the intervention. They were also shown that they had access to a website called Beam Feel Good, which is an online video repository that has exercise videos that use limited to no equipment, and they're available free of charge to individuals with cystic fibrosis. Those that were randomized to the intervention group received an incremental exercise increase prescription, and you can see at the bottom left what that would have looked like. So from weeks 1 to 2, they were asked to participate in 60 minutes minimum of physical activity in a target heart rate zone that was determined from the heart rate reserve method, so based on their resting heart rate and the maximum heart rate that they achieved during their incremental meter shuttle walk test. This was calculated on site for them and then given to them. And then by week 9 through 12, we were asking them to participate in 180 minutes of physical activity as their baseline. The exercise that they participated in was self-determined. So they were assigned an exercise coach who would contact them weekly through a method of their choice. So either messaging, phone call, or virtual meetings. Almost everybody opted into texting, messaging with the occasional supplemental phone call. And the exercises that they did needed to be within their target heart rate zone and within their minimum target heart rate, or within their minimum exercise minutes, but they were allowed to determine what it was that they wanted to do. So whatever they had access to is what we would utilize. After 12 weeks of being in the study, both the usual care and the intervention group would come back in and go through all of the same questionnaires, xenon MRI, and the incremental shuttle walk test. Those within the intervention group also did a semi-structured interview at the end discussing their exercise experiences. We did lose a few to follow up. The primary reason was reschedule conflicts. It was very difficult to get everybody in for a full day to do xenon MRI and everything else. So we had a couple of different primary outcome measures. Within our pulmonary function, we utilize xenon MRI as a novel way to look at pulmonary function. We know that with those on highly effective CFTR modulators, we see an increased stability in FEV1% predicted. So xenon MRI was used to look at ventilation defect percentage as a potentially more sensitive way to evaluate changes in lung function. And then we also looked at forced vital capacity, FEV1% predicted. We use the incremental meter shuttle walk test as a method to evaluate cardiorespiratory fitness. This is a great way to look at cardiorespiratory fitness without needing to utilize a CPET. For those of you who are unfamiliar with the test, throw yourself back to middle school and picture, I know nobody wants to do that, picture the beeper test. So you start at one set of cones and then you hear a beep and your goal is to get to the other cone before you hear the next beep. This test slowly increases in speed until individuals are jogging, and it can end in two different ways. So either somebody feels too short of breath and fatigued to continue, or they are unable to keep up with the set pace of the test. We also did a few additional surveys, so CFQR, we evaluated exercise preferences and barriers, and then a semi-structured survey for those in the intervention group. I only want to highlight a few things on this slide. So primarily that for enrollment within the study, individuals could not already be participating in greater than 150 minutes of physical activity per week. Our end goal was 180 minutes, so we didn't anticipate really seeing any change in outcomes for those who were able to add an additional 30 minutes per week. We also needed approval from the primary CF physician for the individual to participate in an exercise intervention. And then just again, they were all on highly effective CFTR modulators. Now, within our baseline characteristics, our participants were relatively similar. Of those that completed the intervention, age, CFQR, and incremental meter shuttle walk test were all very, very similar. The only difference that we really saw was between FEV1% predicted at baseline. So the intervention group had 88% predicted, and our control group had 81% predicted, so a little bit of a discrepancy. The images up on the screen are 3 representative images of our control group and 3 representative images of our intervention group. Just to kind of orient you, any of the blue areas are areas where ventilation is occurring, and any of the black areas are areas where we don't see any ventilation. Now the image on the left-hand side of the screen is looking at the ventilation defect percentage, and obviously we want this to be much smaller. So this is just comparing all of our study participants, intervention and control, against healthy individuals. So you can see there's obviously a really big spread within those with cystic fibrosis, even though our particular group tended to have a fairly high FEV1% predicted. The image on the right-hand side is actually showing our control versus our intervention group. So there was not a difference in ventilation defect percentage between our two groups at baseline. Now, I'm going to go into some of our results here. Our biostatistician is actually still currently crunching some of the numbers, so I don't have a full statistical analysis to provide you with, but I can talk about some of what we saw. So this image is showing the difference in pre to post distance in the incremental meter shuttle walk test between our two groups. I think this is probably where we saw the greatest change. So those in the intervention had a mean gain of 104 meters distance, and those in the control group lost an average of 66.6 meters from pre to post test. Both groups had a small gain in their CFQR score, intervention of 3.9 points and control of 2 points. This is not clinically significant. And then, as anticipated, FEV1% predicted remained stable. We really did not see a difference in this with either group. Now, within our Xenon MRI results, this is showing those 3 controls and 3 interventions, their pre and post images. Now, in either group, we did not actually see a statistically significant change in their ventilation defect percentage from pre to post testing. However, if we compared the change in ventilation defect percentage to the change in shuttle distance, we did see a trend. It was not statistically significant, but we also had a rather small sample size. We conducted semi-structured interviews with those in our intervention group, and I am particularly fond of this quote. So the Murmis referred to in these slides is actually Dr. Murmis. He's one of the CF physicians in our outpatient clinic. I think that this semi-structured survey quote does a really good job kind of showing some of the themes that we found from all of our participants, which is that once they were actually able to incorporate exercise into their daily routines, they had an improved mood, a decrease in stress, and just overall kind of felt a lot better. Those within the intervention group had a decrease in perceived barriers to physical activity, and those in the usual care group did not. So what are our conclusions from this? Well, this is a pretty small sample size, so obviously it needs to be interpreted cautiously. Our early results show improvement in cardiorespiratory fitness and a reduction of perceived barriers to exercise, but limited change in CFQR and FEV1% predicted. Xenon MRI ventilation defect percentage did not change over the study period, but it did trend with changes in shuttle distance, CFQR, and spirometry. So further studies on the impact of sustained exercise in people with cystic fibrosis are needed. So I think something that we can kind of conclude is that exercise is generally beneficial in individuals with cystic fibrosis, but it doesn't specifically appear to improve CF-related lung disease. Here are some pictures of some of our primary study team members. Dr. Murmis might have been able to sneak into the room. I think it was, yeah, I see his hand. Okay, so Dr. Murmis, you met him earlier through the semi-structured quote. Dr. Dave Burnett is the PI on this study. Allison Bustos might also be here today. She was one of our recruiters and also one of our exercise coaches. And then Dr. Nabalski, he was kind of our Xenon MRI expert. And I would be happy to take any questions that you guys have at this time.
Great presentation. Thank you. So, with the shuttle walk test, you showed that there was an increase in 104 meters. Mm-hmm. Is there any data to support a mean critical difference for clinical significance in the shuttle walk test?
That is a really good question. I don't believe that there is in individuals with cystic fibrosis. Now, in terms of like a 6-minute walk distance, we do have, a minimum clinically significant important difference, but we don't necessarily for this particular test. So not the incremental meter shuttle walk test.
I was just going to comment that it exceeds the minimally clinically significant difference in normal individuals. 104 meters would be above that. So
perfect. Thank you so much.
This was a very interesting talk. Thank you. And a very interesting study. Do you plan to follow up with those patients if they stick with doing exercise? Because we have a very similar study and have such a hard time recruiting them and even continuing to stay in the study and doing it.
Right.
So that's why I'm just wondering if you...
So that is an excellent question. In terms of the actual study data, no, but I can tell you anecdotally that we do still see these participants in clinic. So it seems to vary between individual to individual. I did forget to mention during the presentation that they were given a Garmin Vivo Smart 4 to record their heart rate and exercise minutes. Some of them found, and this was returned at the end of the study, so some of them found this to be a really good motivator. They found that they were able to kind of track their data really well, and so it motivated them to kind of continue working out. And then for others who kind of discontinued activity, or at least did not continue it as consistently after the study ended, they reported that without having somebody to kind of, they said, hold them accountable, even if it was just a small check-in, that it was hard to consistently maintain physical activity. But most of them seem to have kind of an on-again, off-again relationship with exercise now, where they get on the ball a little bit, they exercise, and then they kind of fall off the wagon a little bit, and then they hop back on again. So that's kind of where most of them seem to be at this point. And we did have some who enrolled in actual courses. I think there's one called Orange Theory we had somebody enroll in, and so they've actually maintained those courses since discontinuation of the study.
Yes, a nice presentation, Berlinski from Little Rock. I have a question regarding your MRI, and was the MRI standardized for its relationship to airway clearance? Because there's data that shows that after having completed your treatment, there are significant changes. So,
do you mean like where within? Oh, like within?
Well, how long after? So, have they all done their session before you're done your MRI or not? Because if not, then it's going to be very hard to compare, because that's something that's varying over time. Mm-hmm. So it depends on where are you taking
Right.
pictures.
Right. And I did forget to, sorry, this is my first presentation. I got a little nervous up here, so I forgot to mention some things.
You did a great
Thank you. Yeah. So for their MRI, we did have that pretty standardized between everybody. So if they had assigned and scheduled morning treatments, they would do it, but we didn't do morning MRI. And so there would be several hours in between. And then all of the shuttle walk tests were conducted after MRI just to count for any kind of false inflation, inventilation that we might see just from kind of jogging during that test. So that was kind of like a hard stop shuttle test always after MRI just to avoid that.
There's one question here that came in from the app that says, what was the name of the exercise app for persons with CF again, which I think is in reference to Beam, the website.
Yes,
Yeah.
beamfeelgood.com. They have some excellent videos. Some of our participants really found the dance videos to be very nice. They have some pop songs, things like that. And then some of them really liked the resistance band videos or like the free weights. They have a lot of great stuff.
And Abby's in the back, so she can correct me if I'm wrong, but I'm pretty sure that it is still free for adults with CF in the US right now. So that platform is a really excellent resource for patients for at-home exercise that really requires minimal equipment to be able to participate in it. And it is something that they can access for free right now. So if you do have a PT in your clinic, most of them probably know how to access that. But a few of us that are here in the audience can help with that too if you have more questions. If people can bear with us, thank you so
Great,
much,
thank
Ashley.
you.
We have one follow-up. We have an informal poll for the audience. There we go. So just because we spent a lot of time reviewing abstracts and going over things for this session, and we figured we might end up with a couple of extra minutes, we wanted to just ask the audience a couple questions after seeing all of the research that was presented today. There's no pressure here. This is just a raise your hand situation. But so first question is, do you think physical activity and exercise is important for people with CF? There we go. Beautiful. Okay. So that leads to our next question is anybody here actively conducting any type of research related to exercise in CF? So that could be a QI project, a pilot project, something that's funded. I know that there are people out there. Yeah, all kinds of people out there. So this, Ryan and I wanted to really encourage everybody to consider abstract submission for NACFC next year, sharing within your discipline, putting stuff out on your listserv through the CF Foundation, because as we've all seen with what we got today, exercise is really important and only becoming more important for patients that are living with cystic fibrosis, especially as they continue to live longer and healthier lives, which is all of our goal. We've heard some really interesting things over the course of the last 2 days, including, some research that's going to be coming out of the UK with the EXACT trial, looking at exercise as airway clearance. And, clearly a portion of our patients are trying to use exercise to substitute for some of their other treatments. So please, please, please do all the research projects that are out there and tell all of us about it, because we'd really love to hear about it next year. And thank you, everybody. Thank you to our speakers, and thank you for the audience to come for attending.